talk about this kind of historical concern for haloperidol and other antipsychotics causing prolonged QTc and sort of that association with serious events like arrhythmias, torsades, and sudden death, which, I think is interesting in that, IV Haldol remains contraindicated due to this risk. There's a black box warning from the FDA, and yet there are very few IV options for delirious patients that are agitated, and Haldol, both IV and otherwise, I think has been used for many years by many clinicians without much evidence of significant events in sort of the clinical experience. So this is just an introduction here about Haldol. I include this just to say that the mechanism's not clearly established. We know that it works on dopaminergic receptors and improves hallucinations and agitation, but that it also acts on other channels in cardiac cells, for example. And this is their official warning from the FDA. This association with QTc and torsades, and they say that high doses and IV Haldol can cause this, and you should be very cautious, and that IV is contraindicated. You can see that's very clear and in all caps down there at the bottom.
It's not contraindicated, it's not approved.
Not approved, sorry. Apologies. Not approved. But this is the American Psychiatric Association guidelines for 2006, and they do recommend IV haloperidol as the preferred treatment for agitation in delirious patients. There's kind of some guidelines about the dosing, which I think will be relevant throughout the presentation, but that you can start with 10 milligrams IV in severe agitation per their recommendations. So this is just a little bit about the QTc interval, which I'm sure all of us are aware of. It's the time between the QRS and the end of the T wave, which includes ventricular depolarization and repolarization, which is the T wave, Q wave and T wave. And we often correct it to the QTc because of the changing heart rate. And these are kind of rough guidelines that you'll see throughout the literature and in resources about what's normal, borderline, prolonged, and of concern regarding this relationship with torsades, ventricular arrhythmias, and sudden cardiac death. And this relationship between prolonged QT and these arrhythmias is modest at best, per my understanding of the literature, but there's no alternative superior data point to gauge the risk for these arrhythmias, so it's often used in this setting. But important to realize that electrolytes like mag and calcium and potassium, sinus node dysfunction, heart block, MI, congenital prolonged QTc syndrome, medications, critical illness, comorbidities, frailty index points, all these things can also increase the risk. Torsades is translated to twisting of the points. As I mentioned, critically ill are at increased risk. A lot of these studies that we're going to talk about today look at the incidence of serious adverse events like arrhythmias and death in critically ill patients. So, the reason, or part of the reason they're at increased risk, is because they're often on arrhythmic drugs, or pro-arrhythmic drugs, I should say. They could have renal or hepatic impairment. Their lights could be abnormal, and they may have arrhythmias or a bit increased risk for other reasons. The American Heart Association suggests that any patients meeting at least one of these three criteria should be monitored while they're in the hospital, with telemetry or ECG monitoring. So here I wanted to talk a little bit about kind of the drugs that have been shown to prolong the QTc and kind of that relationship. And this is the cardiac action potential here, and you can see the ECG strip as well. And we have seen that there is a relationship between prolonged QTc and torsades, sudden death in post-MI patients and patients with long QTc syndrome, and this is based on large epidemiological studies, and I think this is fairly well established in the literature relative to the other QTc. But it's important to realize that not all QTc prolonging drugs have been associated with torsades. And an example of this is amiodarone. It's class 3 antiarrhythmic, which it acts on sodium and calcium channels, but it blocks potassium channels as well and prolongs repolarization, and that's thought to be the primary reason that it prolongs QTc, but it rarely produces torsades. Whereas quinidine, which is a class 1A antiarrhythmic, blocks the fast inward sodium channel and is associated with less severe QTc prolongation, but more frequently produces torsades. This is kind of a wordy slide, but this is just a reference to the idea that tricyclics have also been shown to widen the QRS and prolong the QTc via their effect on conduction and depolarization in the heart, but that they act in slightly different ways, and that with regard to the repolarization in the potassium channels, the primary cause for QTc and torsades in drug-induced QTc prolongation is thought to be mediation of this hERG potassium rectifier channel. And it's pretty clear that drugs blocking this channel, there's a lot of studies from the early 2000s, can cause arrhythmias and induce torsades and sudden death in healthy patients. Originally, this was seen in cardiac drugs and cardiac patients because that's where the data was, but another example of this is recently enough we've determined that in congenital long QT syndrome type 2, there's reduced functional expression of the hERG gene product. So this is all to say that we think that the potassium channel in this setting is the likely cause. If you look at first-gen antipsychotics, thioridazine the highest risk and does block this channel and is high risk relative to TCAs, which both slow conduction, and haloperidol likely works via this mechanism as well in a dose-dependent effect. I think this slide is helpful to see the relationship between these sodium and potassium channels and this potassium efflux channel, which the effect of these drugs is thought to, or particularly the antipsychotics, is thought to prolong the QTc. This is the history of this concern. There's tons of studies looking at this. I thought this was really interesting. So the first concern came in 1963. There were two patients getting large doses of thioridazine, 1,500, 3,600 milligrams daily, and their ECGs had alternating heart block and VT before they died. Torsades was first described a few years later in 1966. Haldol was approved in 1967. It was studied in the 70s in very large populations of healthy patients, or otherwise healthy patients, and tolerated very well at doses of 1 to 100 milligrams daily. And there was a study in Finland in 1991 where they looked at all of the medical legal, all the coroner cases in Finland. There's 24,300-ish cases, and 46 of them were taking psychotropic medications, the vast majority of which were on multiple medications, but I think in 26 of those 49 patients, they were taking either thioridazine or Haldol, typically at pretty high doses. And the percentage of those patients on Haldol was very small. And notably, these patients had risk factors. They were on medications for schizophrenia. There's a high prevalence of smoking and other cardiovascular risk factors in this population. Then there were 3 case reports published in 1993, which really seem very frequently cited in the literature. And these were post-op cardiac patients with fairly significantly prolonged QTc. that got very large doses of Haldol. You can see like 230 milligrams, 420 milligrams IV Haldol daily. This first case had a QTc of almost 600, got 180 milligrams of IV Haldol over 4 hours after that, and then went into torsades. This third case was a woman who'd gotten mitral and aortic valve surgery, and her QTc was 450, so that was the lowest. But even she had gotten significant doses daily and then got like 5 milligram doses Q1 hour times 5 before going into torsades. And all these patients had alcoholic cardiomyopathy and impaired systolic function. So you could argue that they were all at relatively high risk. And then there was a second report of 4 patients over 1,100 patients over 4 years. That was in 1993. They were all intubated, critically ill patients. They had all gotten IV lorazepam as well in 1995. 3 more cases of high-dose IV haloperidol causing QTc prolongation. And I think the doses are interesting here because the lowest dose was 35 milligrams. So you can start to see that, this QTc of 450 and this dose of 35 milligrams is starting to be sort of the lowest QTCs and doses of Haldol associated with this concern. But more frequently, it's much higher doses and much higher QTCs. But in this case, these patients did not have any, low potassium, low mag, bradycardia, MI, other QTc prolonging meds, and their heart function was good, which was different from previously. 96. Sortendol was another antipsychotic, but that was not registered in the U.S. because of 12 sudden unexplained deaths and prolonged QTc interval association. And there's another retrospective case control study, 1998, showed that 8 patients got torsades with significantly higher risk at 35 milligrams per day and QTc at 500. So these seems to be some of the hardest data as far as the QTCs and doses at that time. And then FDA had Pfizer do a big study looking at 6 of the antipsychotics in 2000 as far as QTc and cardiac events, and then subsequently the black box warning for thioridazine was placed, and then later mesoridazine also got a black box warning. And this is just a snippet from that FDA study in 2000, which I think is a big part of how they support their current recommendations. And you can see that thioridazine, despite being given at half its maximal dose, all the other antipsychotics were given at their maximum therapeutic dose, produced the most significant QTc prolongation, and haloperidol really only prolonged it by a mean of 4.7 seconds. And this chart is a little interesting in that they tried to control for, the possibility for other drugs contributing to QTc prolongation in terms of, increasing the concentration of the antipsychotic due to the, like the CYP 450 system. And you can see that they looked at some QTCs in the setting of antifungals and SSRIs and things, which is something to be aware of clinically. So this is sort of the current understanding in my mind of where we are. And we're going to look at some data here in a second that's been more recent. But you have this historic association with these reports of torsades, but relatively limited data from case reports and retrospective studies. And these recent meta-analyses that we're going to look at may contradict this association or may show that we need to do more work to determine if this is really the case. And that, we do typically see it in really large doses in patients that are already at risk. So perhaps it's occurring for other reasons. So this is kind of the first one we're going to look at. This was a systematic review and meta-analysis from 2019. They looked at 2,500 ICU patients, 6 RCTs. They got 1 to 5 milligrams of Haldol, Q6 to Q8, and they did not demonstrate any clinically significant difference between all-cause mortality or the incidence of delirium, and there's no significant association with serious or increased risk for serious adverse events or QTc prolongation. And all of this data that you're going to see is relatively limited and could be expanded upon, but I think you'll start to see some trends here. And this is obviously a lot to look at from the back, but this is just to give you some insight into the relative risk of serious adverse events in QTc, which is similar and not clinically significant between Haldol and placebo. This is another meta-analysis and systematic review of 8 RCTs, some of which were the same as the previous study, and again, there was no significant relationship between haloperidol and reduction in delirium, which is significant relative to placebo. Significant, just to keep in mind that haloperidol does not reduce the incidence of delirium in this setting, but it also does not significantly increase mortality or EPS effects or QTc or increased arrhythmias relative to placebo. And again, here's kind of the visual representation of that. You can see B is at the top there, and that's QTc prolongation, and arrhythmias is C there at the bottom. And here's another systematic review and meta-analysis from 2023 in critical care. We did 11 RCTs, 2,200 patients, 5 placebo-controlled. They looked at mortality and serious adverse events as their primary outcomes, and there was no significant difference between haloperidol and other antipsychotics listed there. And you can see that, with regard to mortality and serious adverse events there, haloperidol versus placebo, really no clinically significant increased risk. And they also looked at QTc as an exploratory outcome. They could only identify 2 trials that they felt were, low bias enough to include, but they demonstrated very similar rates of QTc prolongation relative to placebo as well. Although they do say that there's low certainty of evidence. And here is the all-cause mortality of placebo versus haloperidol. Then in 2020, they looked another systematic review, looked at 77 studies, 34 clinical trials, 34 case reports, and again, kind of similar findings there. And they suggested that we have some evidence-based recommendations for prescribing in the hospital, and their recommendations were you should probably consider monitoring the ECG for doses of higher than 5 milligrams of IV haloperidol, and you should use telemetry only really in high-risk patients who are getting cumulative doses over 100 milligrams or have a QTc over 500. And this is a recent article from NEJM in 2022, which was a multi-center blinded placebo-controlled trial. They looked at 1,000 patients randomly assigned to IV haloperidol or placebo. They were ICU patients with delirium. They looked at days alive and out of the hospital at 90 days. And they did find that mortality was significantly lower in the haloperidol group, with similar rates of serious adverse events and QTc prolongation across the 2 groups. I apologize, I wanted these to come in one after the other, but you can see that graph is haloperidol relative to placebo in terms of mortality over time, and you can see that placebo death, mortality risk relative to haloperidol, placebo. Here is another study from 2013, double-blinded, placebo-controlled, randomized trial, 141 critically ill patients. They got 2.5 milligrams IV Q8 versus placebo, and they did just fine. And again, I feel like I'm getting a little bit monotonous here, but you can see that there's similar data. And this is, I thought was interesting, this is a clinical decision analysis. And they concluded that haloperidol actually had the lowest effect size on QTc interval prolongation relative to other antipsychotics, some of which have never been associated with torsades or sudden cardiac death. And this was published actually just a couple days ago on the 24th in JAMA, an RCT of 566 patients. This is a secondary analysis. And some of these patients had up to QTCs of 550. They were randomized to haloperidol, ziprasidone, or placebo twice daily, and neither was associated with increased QTc compared to placebo, and no drug-related fatal arrhythmias occurred. This is kind of their picture, which I thought was nice and easily absorbed. But this is kind of their scatter plot understanding of kind of the relationship between QTc prolongation of these two drugs and placebo, and you can see it's very, very similar. So my conclusions, takeaways, I think that we understand that, a QTc interval of greater than 440 is high, and that 1/500 is associated with increased risk of arrhythmias like torsades. But there's lots of other things that we should keep in mind, like their cardiac history, their electrolytes, meds, and that things like critical illness and hepatic and renal impairment can also cause this. And that, yes, we do see more sudden death in patients on antipsychotics, but it's relatively low incidence, and these patients have risk factors. And that this association historically is based largely on case studies, case reports, retrospective studies in high-risk patients. And that we know PO and IM haloperidol is very well tolerated, up to 100 milligrams in healthy populations. And these recent studies suggest that haloperidol can also be used safely in hospitalized patients, may even decrease mortality, and likely does not increase the risk of serious events or arrhythmias. May not even increase QTc relative to placebo or other drugs that have been associated with torsades in the past. And I think as far as, clinically, alternative IB agents are often unavailable. So back to my medical myth, which is that haloperidol should be avoided in hospitalized patients with prolonged QTc due to the risk of serious adverse events. I think that we have demonstrated that it's really not associated with increased mortality or serious adverse events compared to placebo in critically ill patients, and can be used with caution. And that the risk of this QTc prolongation in torsades is based on historical data and may not be clinically significant, particularly at low doses in otherwise healthy populations. And this is my works cited. And yeah, questions?
Thank you, Will. This was such a good review. Did you forgive the conspiracy theorist theme, but did you come across anything that indicated the reason for the FDA statement in the early 2000s? It happened, as I look at the approval timing of olanzapine, it happened around the same time as some of the newer antipsychotics were being developed. And again, I, this is not to say actually that there was profit driving it, but actually was it that there was a safer set of alternatives that were being rolled out and that there was maybe some pressure to lean on newer, safer? I just wondered if that was a theme in anything that you saw.
I think that my impression was that they didn't have a whole lot of other options, but did have a lot of data at that time with thioridazine causing it. So put out the black box warning just to make sure that clinicians were sort of aware of the risk. And then only later did they have significant data suggesting that olanzapine, quetiapine, or risperidone aren't really associated with this. And I think with time, perhaps, it'll be clear that was sort of a preemptive thing that they just wanted to get out there as a possible concern relatively. I don't know if that answers your question super well.
So, I mean, I think this is a good example of how a lot of times these things get started with case reports, and somebody draws some sort of association or conclusion based on a case report or a small series of case reports. FDA, I think, is sometimes they're cautious. I don't know whether they're overly cautious, but this isn't the first drug that they've put a black box warning on that eventually was shown to be safe. The problem is they almost never get rid of the black box warning even after it's been pretty much demonstrated that the drug is safe. I'm not sure why that is, but that's been a pretty consistent finding, and we've done some other Mythbusters where we've seen the same thing happen. Yeah.
Question, do you know why they picked on IV haloperidol? Since IM gives similar blood levels in a similar time frame?
Yeah, if we go back to these case reports, the first really clearly documented incidents of these, cardiac arrhythmias were in the hospital because they had them on, telemetry already. And they were all given large doses of IV Haldol. So the most clear association and risk was in that setting while they had been studying PO and IM haloperidol in very large epidemiological studies and felt that they were very safe. So they had these kind of two sets of data. One was very limited in the hospital setting in high-risk patients, in my opinion, but had clearly demonstrated this relationship to IV Haldol.
Okay, so I think it's past time to vote. We're running late. So, is it a myth? Haldol should be avoided in hospitalized patients with prolonged QTc greater than 440 due to risk of various adverse events, including arrhythmias such as torsade and sudden cardiac death. How many people think that this is a true statement, that we should avoid Haldol in these patients? How many think that it's plausible? How many think that this is busted? Looks pretty unanimous. Okay, well. All right, we're busted.